So welcome. I'm Ann Sosa from the Duke Department of Surgery. We're going to be talking today about the epidemic of thyroid cancer that's being observed in the United States, as well as our evolving surgical and medical management strategies. These are my only disclosures. So there is a veritable epidemic of thyroid cancer that has been seen in the United States. Over the last 30 years, the incidence of thyroid cancer has increased nearly 300%. And it's really a pandemic that is being observed around the world. Almost every developed and developing country has seen a rapid increase in the incidence of this disease. The overwhelming majority of thyroid cancer cases are now papillary thyroid cancer, which accounts for nearly 90% of all new cases. In this year alone, there will be more than 62,000 Americans diagnosed with thyroid cancer. While we're making great progress with regard to the diagnosis and treatment of this disease, we are still losing some ground in mortality, in that the mortality rate has increased approximately 27% in the last decade. Certainly there is increasing public awareness about thyroid cancer and the importance of self-examination. Typically, thyroid cancer presents with a nodule or a lump in the anterior or lateral neck. This is one example of a public health campaign, although to the best of my knowledge, Brooke Shields does not herself have thyroid cancer. So thyroid cancer is the most common endocrine malignancy, and in women under the age of 35, it is the most common cancer diagnosis. Among both men and women in the United States, it is the fastest increasing cancer. In 2005, it was the number 8 cancer diagnosis among women. By 2013, it had become number 5, and it is anticipated that by 2019, thyroid cancer will overtake both colorectal cancer and uterine cancer to be the third most common cancer diagnosed among American women. So this is clearly a very important public health problem. So one of the things that I think bothers me the most is when I hear providers, patients, and the public say that thyroid cancer is the good cancer. To my mind, there is no such thing as a good cancer. But what I think is meant by that is that most people, fortunately, do not succumb to thyroid cancer. Rather, it's an indolent disease with an excellent survival rate, typically quoted as above 92 to 95% over 5 to 10 years. But it is a diagnosis that people live with, which means that they must continuously undergo surveillance, imaging, and blood tests, and in many cases, additional treatment. What that means for patients, their families, and the healthcare system is that the cost of care for thyroid cancer is quite extraordinary over a patient's lifetime. What you can see over the last several decades is that it is anticipated that with increasing incidence and prevalence of the disease, the cost of care for thyroid cancer will continue to rise. Where is most of that coming from? Well, different things, but largely from what is shown in green, and that is surveillance studies that are performed to exclude either persistent or recurrent cancer, which is typically seen in between 20 and 30% of patients. As a result, thyroid cancer is the 7th most common cancer diagnosis associated with bankruptcy. Why? Patients live with their disease, accumulating over the course of decades the costs of remedial treatment, remedial diagnostic studies, and surveillance studies. And what is extraordinary is that in the end, thyroid cancer is more commonly tied to patient bankruptcy than even such mortal diagnoses as lung cancer, leukemia, and lymphoma. In North America, we are seeing an increase in thyroid cancer across the board in Americans who are of all ages, both genders, and in all stages of thyroid cancer. Although clearly what you can see in the figure to the right is that cancers that are small and localized to the thyroid are those that are being identified the most frequently. Papillary thyroid cancer is exploding in incidence, although other forms of differentiated thyroid cancer, including the follicular variant of papillary thyroid cancer and follicular cancer, are also increasing, but at much slower rates. And again, this is not a phenomenon unique to the United States, suggesting that this is not just an artifact of Americans spending more money on surveillance imaging studies resulting in the incidental diagnosis of subclinical disease. Rather, it is a phenomenon that is being seen in virtually every country around the world, although you will see in the figure that in the United States, we're number 2, right behind Israel, in terms of rapidly increasing rates of diagnosis. In the New England Journal of Medicine, one of the cover stories recently was one demonstrating the effect of having a population-level screening program for this diagnosis. And what you see from the figure is that as a result of screening Koreans, this is in South Korea, for thyroid nodules with ultrasonography, this resulted in a 4 to 5 times higher rate of increase in South Korea compared to the United States at the population level. Indeed, the result of this phenomenon was near bankruptcy for the South Korean healthcare system, and it resulted in the stoppage of that ultrasonographic screening program. And unfortunately, while we as providers are doing a much better job, I believe, of taking care of Americans with cancer, thyroid cancer is one where we're doing a little less well. There are only 6 cancer diagnoses where mortality rates are still increasing and not decreasing, and as you will see in this figure, thyroid cancer was number 2. That's a list you don't want to be at the top of. We expect, if anything, a continued acceleration of the epidemiologic phenomenon that I have described. That is because we know that with age, the incidence of thyroid cancer increases, as does the aggressiveness of the disease. And from this figure, you will see that there is a graying of the American population. And with this, we will see continued increase in incidence and, if anything, increasing aggressiveness of the diagnosis. Well, in part, some of what I've shown you is an artifact of what we are doing as providers. And what we're doing is we're doing more and more imaging studies, whether those are CAT scans, PET scans, MRI, carotid duplex, or ultrasounds of the neck. When a thyroid nodule is seen and a cancer diagnosis is entertained, typically an ultrasound-guided fine needle aspiration is performed. you will see that over just 5 years, there was observed a 107% increase in the number of thyroid fine needle aspirations performed. Fortunately, the overwhelming majority of these were ultrasound guided as opposed to palpation guided, which really don't have a place in practice in 2015. As a result of this, the number of thyroid FNAs performed in the U.S. has more than doubled. And indeed, of all biopsies performed in the United States today, approximately 65% are biopsies of the thyroid gland. This is a figure culled from SEER, looking at nearly 20 years of data. And what you can see is that the incidence of thyroid cancer at the time of diagnosis is increasing for tumors of all sizes, but clearly increasing the fastest among the smallest tumors, those under 1 centimeter in size. And when we're referring to papillary cancers under 1 centimeter in size, we call these papillary thyroid microcarcinomas. And this is a very common thing. Well, providers alone are not the only source of new cases of thyroid cancer. We suspect, given the worldwide phenomenon that is being seen, that there are other potential environmental or lifestyle factors that are contributing to increasing incidence. What might they be? I think they would include increasing exposure to ionizing radiation, potentially lifestyle-related factors such as obesity, smoking, and diets that are changing, and finally, potentially environmental pollutants, including polychlorinated biphenyls, dioxins, and polybrominated diphenyl ethers, a common component of flame retardants, which can be found in the workplace as well as the home. Well, let's start with radiation. Clearly, there is increasing exposure to ionizing radiation in the United States. In the early 1980s, the effective dose per American was about 3.6 millisieverts. By 2006, this had nearly doubled to 6.2 millisieverts. Where are the exposures coming from? Clearly, the medical sector is in large part to blame. In the 1980s, medical exposures accounted for just 15% of the radiation exposure, but by 2006, this had increased to 48%. Well, is this the most important explanation for the public health phenomenon? I don't think it is, and I would argue it's not just radiation, because at the same time there has been increasing exposure to radiation, we have seen a simultaneous decline in somatic mutations of tumors that are radiation related. So RET PTC is a somatic mutation that is clearly related to ionizing radiation. But what you will see in the figure to the right is that the incidence of RET PTC mutations is falling. At the same time, there has been a rapid rise in the incidence of BRAF V600E mutations in papillary thyroid cancers, such that approximately half of all new papillary thyroid cancer diagnoses are associated with BRAF V600E. But this mutation has no known association with radiation exposure. So many epidemiologists have been fascinated by the trends that I've shown you. And a recent pooled analysis of 5 prospective studies at a population level looking at potential causes for thyroid cancer made several important and interesting discoveries. First of all, unlike what is true for many cancers, if anything, cigarette smoking is associated with a reduction in risk for thyroid cancer. So too is increased alcohol intake. However, increased body mass index or obesity is associated with an increased incidence of thyroid cancer, as is increased physical activity. And certainly I would not argue to smoke or drink simply to avoid a thyroid cancer diagnosis. So there's a lot going on, and what have we as thyroid cancer providers done to respond to the public health challenge? So I think the first thing we need to do is to standardize our treatment in order to eliminate variation in practice that could lead to a simultaneous reduction in the quality of care. There are a number of different guidelines, practice guidelines, that exist both in the United States and around the world, but arguably the best read are those that come from the American Thyroid Association. Prior guidelines were issued in 2006 and 2009. New guidelines were initially anticipated in 2013. Unfortunately, that deadline was missed due to the increasing volume of research and publications in the field. They were then expected in 2014, but that deadline came and went, and so finally they were published in 2015. Clearly, the research has been a process of evolution, as has the way we behave in response to evidence-based guidelines. There is certainly not a revolution afoot. And the ATA management guidelines for adult patients with thyroid nodules and differentiated thyroid cancer were finally released in October 2015. These are publicly available to both patients and providers, and I'd encourage all to have ready access to the document. A number of thought leaders from many different disciplines participated in these ATA thyroid nodule and cancer guidelines. It was truly a transdisciplinary and international effort to assemble the best evidence in order to inform the wisest practice. I had the good fortune of serving on the task force responsible for writing this document, which has more than 100 recommendations and consumes more than 400 pages. We're going to be focusing today on those guidelines that most directly apply to surgeons, and there were 4 surgeons on the committee. 2 surgeons, Drs. Stewart and Doherty, were on the prior guidelines committee. Dr. Randolph and myself served for the first time on the 2015 task force. And you will see that there was equal representation from both otolaryngology and endocrine surgery. So what are the paramount goals of the new ATA guidelines? Well, several are shared with other guidelines from other professional associations and prior versions of the ATA guidelines, including a goal to improve cancer-related survival, to minimize the risk of disease recurrence and metastatic spread, to permit accurate long-term surveillance for disease recurrence, and to permit accurate staging of the disease. But for the first time, a centerpiece of the guidelines is to assure we are not over-treating patients, that is, exposing them to risks that are not justified by benefits. So what's the take-home? If I were to summarize it in a nutshell, it would be the mantra, less is sometimes more, and more is sometimes less. Well, as surgeons taking care of patients with thyroid cancer, how can we know how much surgery is too much and how much is not enough? Well, I would argue on one side of the balance, we have to avoid undertreating those cancers that are clinically significant, that is, that could recur or even shorten a patient's life. At the same time, we need to avoid the overtreatment of indolent lesions that can remain subclinical for decades or even a lifetime. Well, how do we weigh risks and benefits? I think there are many factors, and in the United States, those clearly include the risks of misdiagnosis leading to long-term outcome uncertainty. Patient preferences must be the centerpiece. Medical legal considerations are always at the table. And finally, we have to be cognizant of costs to both patients and payers. So let's turn back to those papillary thyroid microcarcinomas that we talked about earlier. That is, those very common and increasingly common tumors that are under 1 centimeter in size. So this is an editorial, a thought piece that was published in 2014 by Thyroid, and it was written by 2 endocrinologists, and this really shook up the thyroidology community, in that the suggestion was made that for these very small micropapillary thyroid carcinomas, we should consider not treating or operating, but actually observing them carefully with fastidious surveillance. So the research question asked is the identification and eradication of all papillary thyroid microcarcinomas a worthwhile goal? Well, before I think we can answer this kind of charged question, we have a couple of challenges. One is we have to be able to confidently identify those tumors that are destined to become aggressive before they develop disease progression, or at least at a point in progression where intervention, particularly surgery, is still thought to be very effective. And secondly, we have to confirm appropriateness and safety of observation before we can advocate dissemination. Well, what do the data show? So, to the best of my knowledge, these are some of the best data published. They are from Japan, from Dr. Ito and his colleagues. In this most impressive, extremely large single institution study, the authors followed more than 1,200 patients between 1993 and 2011. They divided patients up into 3 age groups, and they defined disease progression as they followed these patients by size enlargements, the development of new lateral nodal metastases, and progression to clinical disease, which they perhaps arbitrarily defined as tumors that became 12 millimeters or larger in size, or that develop new lateral lymph node metastases. And what you see in this very long-term cohort study, that while tumors did slowly get larger, and while some developed nodal metastases, the rate of tumor enlargement was extremely slow and only occupied a very small minority of these papillary thyroid microcarcinomas. In addition, fewer than 4% ever developed nodal metastases. They then divided these trends up by age group. And what you see is that the proportion of patients who did develop papillary thyroid microcarcinoma progression was lowest in the oldest patients and highest in the youngest patients. Indeed, on multivariate analysis, young age remained an independent predictor of papillary thyroid microcarcinoma progression. So what did the authors and what can we conclude? First, older patients who have lower risk papillary thyroid microcarcinomas may actually be the best candidates for observation. But what is also true is that while young patients who have papillary thyroid microcarcinomas more often have progressive disease, it appears that there is enough time that with careful surveillance, it is likely you can identify the progression and intervene before it is too late, suggesting that surveillance may be appropriate in a subset of patients with this diagnosis. Well, what can we say about how we're doing right now in the United States with papillary thyroid microcarcinomas? So these are data from our research group here at Duke, and we asked the question, is this PTMC diagnosis an overtreated entity? Unfortunately, we were left concluding that the answer is probably. More patients in the United States are undergoing total thyroidectomy, indeed 3/4 of patients with these tiny tumors are losing all of their thyroid, and nearly 1/3 are additionally receiving radioactive iodine, in spite of the fact there is absolutely no evidence to suggest that either total thyroidectomy or radioactive iodine affords survival advantage for the overwhelming majority of these patients. Indeed, current guidelines suggest lobectomy alone, meaning removal of half the thyroid with no radioactive iodine, is sufficient treatment. So until recently, thyroid lobectomy was the recommended strategy for these tiny tumors. Here is the new recommendation in the 2015 ATA guidelines, and it starts with an important qualifier. It says if surgery is chosen. So that provides a little bit of wiggle room now for providers who decide that they may want, with a patient's permission, to follow this diagnosis rather than surgically intervening. The recommendation goes on to say that for the overwhelming majority of patients who do have surgery, thyroid lobectomy is sufficient for the overwhelming majority. Two notable exceptions where total thyroidectomy might be more appropriate would be in those patients with a history of head and neck irradiation, who might have a family history of papillary thyroid carcinoma, or who already have nodal metastases. Well, I've brought up that age-old controversy. What is the extent of surgery for tumors larger than 1 centimeter? What strategy is most appropriate? Should it be total thyroidectomy or thyroid lobectomy? So we're now going to discuss tumors that are over 1 centimeter in size. Well, what are the pros of performing total thyroidectomy? Many argue that you then eradicate potentially bilateral disease. Secondly, it facilitates the administration of adjuvant radioactive iodine. And finally, our endocrinology colleagues might argue that it facilitates surveillance and makes it easier to detect recurrence with thyroid globulin levels that nadir in an undetectable range. Advocates of thyroid lobectomy counter and say, this is an indolent disease with an excellent prognosis. There certainly are higher risks for complications when we perform more extensive surgery. And finally, they question whether there is indeed a survival benefit that is afforded with total thyroidectomy. Well, what are we doing right now in the United States for papillary thyroid carcinomas? So this is an interesting analysis at a population level that shows, first of all, we're operating more for thyroid nodules, and therefore we're operating more for thyroid cancer. In just a 5-year period, the rate of thyroid nodule-related surgery increased by nearly 1/3. And what you will see in the figure is that it is total thyroidectomy, not thyroid lobectomy, that is the genesis of this increase. Total thyroidectomy is shown with the dotted blue line. But we need to think carefully about doing total thyroidectomy if risk is not justified by benefit. I say that because we now know that total thyroidectomy is associated with more complications, even in the hands of high-volume surgeons. So most who are familiar with research in the volume outcomes area know that as volume of a surgeon increases, the percent on average of complications decreases. While this is blunted for total thyroidectomy, you will see in this figure that even in the hands of the highest volume surgeons, total thyroidectomy is associated with about twice the risk of complications compared to unilateral thyroid surgery or thyroid lobectomy. Well, what are the data supporting this trend towards performing total thyroidectomy? I would argue it's really from a single study published by Billamoria in 2007, looking at more than 52,000 papillary thyroid cancer patients from the National Cancer Database. These investigators looked at overall survival benefit with total thyroidectomy for tumors over or 1 centimeter in size. As a result of this one study, the ATA guidelines in 2009 said thyroid lobectomy should be performed, as we discussed, for tumors smaller than 1 centimeter, but total thyroidectomy is the preferred strategy for larger tumors over 1 centimeter. And these are their data that convinced the ATA to write those guidelines. And you will see in the lower red outline panel that lobectomy was associated with a 31% increase in mortality compared to total thyroidectomy. And I will say this was surprising when it was published to many investigators. Well, after the publication of that study, indeed concerns were raised. In particular, the study had excluded several important confounders that might have explained some of these surprising results, including some patient comorbidities, the multifocality of much papillary thyroid carcinoma, and other pathologic factors, including extrathyroidal extension, as well as the adequacy of resection. There was a subsequent study by Mendelsohn in 2010 looking at 22,000 patients that was unable to replicate their findings in a different database, and these investigators saw no difference in survival between lobectomy and total thyroidectomy. Well, this was a challenge for our research group here at Duke. So we decided to revisit the question and to indeed examine the association between extensive surgery and overall survival among patients with papillary thyroid carcinomas between 1 and 4 centimeters in size. These data were presented at the American Surgical Association and were published in the Annals of Surgery. Like Bill we used the National Cancer Database, but we had access to some additional variables that those investigators did not have access to, and they are shown on this slide. We continued to examine overall survival as the outcome of interest. We looked at more than 61,000 patients with papillary thyroid carcinoma. This is a summary of important demographic characteristics, and I would encourage you to note that while there are statistically significant differences between the two columns of patients, in fact, there really were not clinically significant differences. But when we focused on pathologic characteristics, there were differences between the two treatment groups, and they're not surprising. Total thyroidectomy patients more often had multifocal disease. They had more extrathyroidal extension, more nodal metastasis, more distant metastasis. They more often had positive surgical margins, and more often radioactive iodine was administered. We then performed a multivariate analysis, and unlike Bill we were unable to see a difference in survival between total thyroidectomy and thyroid lobectomy. Our findings were then taken and subsequently have been incorporated in the new 2015 American Thyroid Association practice guidelines. So if we look back at 2005, you will see that for thyroid cancers over 1 centimeter in size, initial surgery should be total thyroidectomy unless there are contraindications or there are some rare confounding factors. But in 2015, there is now choice. And what the guidelines say is that for patients with thyroid cancers over 1 centimeter and less than 4 centimeters, that is patients with low to intermediate risk tumors who don't have extrathyroidal extension, who don't have nodal metastasis, the initial surgery can be either total thyroidectomy, especially for high-risk tumors with nodal metastasis who ultimately might require radioactive iodine, or thyroid lobectomy, particularly for those tumors deemed to be low or intermediate risk. Again, these guidelines are not saying that lobectomy is superior to total thyroidectomy. It is simply saying the two treatment options may in fact be equivalent, and ultimately patients should decide which surgical strategy is taken. So what do I say? Everything old is usually new again. In the end, as surgeons, I don't think we should regulate what operation is done. Rather, I think the operation should be selected in the setting of a larger overall treatment strategy that in the end is formulated by a transdisciplinary team, and patient preference is of paramount importance when we're evaluating the relative risks and benefits of the alternative treatment strategy. Well, a second controversial area in endocrine surgery surrounding the management of papillary thyroid carcinoma is what to do with prophylactic central neck dissection. That is the eradication, potentially, of lymph node metastases in the central neck compartment, called level 6. Before we can answer that question, we have to ask, what is the significance of cervical lymph node metastasis? And once we understand that, then is prophylactic central lymph node dissection warranted? Well, what do the data show? So this was a well-known study published in 2008, looking at more than 15,000 patients with papillary thyroid cancer from SEER. And they divided patients up into those who were over 45 years of age and those who were under 45 years of age in order to reflect the AJCC-TNM staging system. And what these investigators found is that while for patients who are older, there is an association between lymph node metastasis and survival, with compromised survival associated with nodal metastasis, similar findings were not seen for younger patients. A very different conclusion was reached 4 years later by Tran Cao, who looked at more than 49,000 patients, again from SEER. And what these investigators found is that even for young patients under 45 years of age, lymph node metastases were associated with compromised survival, although I will say that there were some caveats or concerns about this study given limitations pertaining to knowing the extent of surgery and utilization of radioactive iodine. Well, when there's disagreement in data, there's no time like now for our research group at Duke to try to tackle this question, to understand whether the presence and number of lymph node metastases are important for survival for patients younger than 45 years of age. Our data and results were published in 2015 in the Journal of Clinical Oncology. These were our two hypotheses. One, that the presence of lymph node metastases and number of metastatic lymph nodes are indeed associated with compromised survival for patients under 45 years of age with stage 1 papillary thyroid cancer. So in agreement with Tran Cao, but this is not reflected in the current AJCC-TNM staging system, where nodal metastases under age 45 years of age are forgiven and do not result in upstaging. Our second hypothesis was that it is possible to stratify a patient's risk of death based on the actual number of metastatic lymph nodes that they had. Again, we used the National Cancer Database and validated our results in the SEER database. We looked just at papillary thyroid cancer in adult patients who had stage 1 papillary thyroid cancer, so no extracervical metastasis, and all patients in our study had to have undergone surgery for their disease. We looked at 8 years of data. We excluded patients who had aggressive variants of papillary thyroid carcinoma, those with multiple cancer diagnoses, and those for whom extent of surgery was unknown or nodulectomy was performed. We were able to adjust in our multivariable analysis for a number of demographic, clinical, pathologic, and treatment variables. In the end, our outcome of interest remained overall survival. And this is a study of our study design, and the important thing is we divided our study cohort up into two groups. Those young patients with papillary thyroid carcinoma who did not have nodal metastasis, that is, they had no evidence of clinical or radiographic metastatic disease in the neck, and a second group who had lymph node metastases and had them pathologically confirmed at the time of surgery. To do this study, we did both conventional, unadjusted, and adjusted survival analysis, but this time we added a novel biostatistical technique. That is, we utilized restrictive cubic splines to look at the effect of number of lymph nodes on overall survival. Many outside of biostatistics clinicians are suspicious of new statistical techniques, so let me just explain briefly what a restrictive cubic spline is. It is a piecemeal polynomial function that allows us to relax the linearity assumption that is made in other conventional forms of multivariable regression analysis. What it allows us, therefore, to do is to examine a relationship between a continuous predictor like number of lymph node metastases and an outcome like survival in the setting of what might be a nonlinear relationship. And these are our findings from the National Cancer Database. This is an adjusted survival analysis, and what you see is that lymph node metastases in young patients with papillary thyroid carcinomas are indeed associated with clinically and statistically significantly compromised survival. We then did the same analysis in SEER to determine if these were robust findings, and the findings were almost perfectly replicated in this second population-level database. We then asked the question, are metastatic lymph nodes associated with overall survival? And what you see is that indeed they appear to be, with the magic number being 6. That is, with each additional metastatic lymph node a young patient has, up to 6 metastatic lymph nodes, there is additional incremental compromise in their overall survival. However, after a patient has more than, say, 6 metastatic lymph nodes, there is no additional compromise to survival. So there's a threshold effect at 6. And that is what this table shows, where you see that for each incremental increase in metastatic lymph nodes up to 6, there is an increase in the hazard ratio, but after 6, there is no longer such a finding. So what are the implications? Well, I think one, cervical lymph node metastases indeed do appear to be associated with compromised survival among young patients with papillary thyroid cancer. Unfortunately, in the current AJCC staging system, young patients with nodal metastases, therefore, are likely being understaged. And finally, we as healthcare providers need to assure that we rigorously preoperatively screen patients for lymph node metastases, and that includes not just older patients, but also this young group. As to whether the AJCC staging system might need to be changed, I think that question has yet to be answered. The AJCC is in 2015 or 2016 anticipated to be releasing new guidelines. Another question asked by the 2015 ATA guidelines is which thyroid nodules should be biopsied. And for those of you who see and take care of patients with thyroid nodules, you know that thyroid nodules can look a million different ways. And it can be extremely hard to triage which nodules merit biopsy and which nodules are likely benign and therefore merit surveillance. Until recently, those kinds of decisions were left in the hands of providers in their clinic, and it can be an overwhelming and challenging decision. The new 2015 ATA guidelines now provide physicians with guidance, and in this figure you will see that, for instance, cysts with a risk of malignancy of under 1% probably don't merit biopsy, while suspicious appearing lesions on ultrasound, like those with microcalcifications, those that are hypoechoic, those that have irregular margins or even extrathyroidal extension and that are hypervascular, should be biopsied. So the guidelines are now very prescriptive, and I think they're more prescriptive with the hope that physicians will feel more comfortable not biopsying many of these thyroid nodules and will be more focused and selective in who to perform biopsy on. So less, again, may be more. Let's finally turn to the use of radioactive iodine. So we're now leaving the domain of surgery and talking about nuclear medicine and endocrinology. Well, you will see from this heat map that the use of radioactive iodine in the United States is extremely varied and appears to follow a geographic pattern in the variation. And of course, variation in practice can be worrisome because it suggests that there is not standardization, and therefore there is likely variation in patient outcomes. Well, how do we decide who to give radioactive iodine to? And I would argue typically radioactive iodine is given based on a concern that a patient will develop ultimately recurrence of their disease. And in 2009, the triage system formulated by the ATA was a low risk, intermediate risk, and high-risk tumor system. And I'll point out to you that those patients who we've been talking about, that is, patients with cervical lymph node metastasis, classically have been placed in the intermediate risk group. And this is the ATA risk stratification system, where you will see low-risk features of cancers at the bottom, extending up through intermediate risk tumors, and in the highest part of the figure, the highest risk tumors. Well, what do we know about how to use radioactive iodine? I would argue that I think there has been consensus for some time that for low-risk tumors, administration of radioactive iodine comes with risk, but without demonstrated benefit. And here you see just one study published in 2012 in the Journal of Clinical Endocrinology and Metabolism, where essentially there is no significant difference in disease-free survival and overall survival among patients undergoing radioactive iodine and not undergoing radioactive iodine. All of these patients had low-risk tumors. Well, what's the downside of radioactive iodine? It is not insignificant. It is known to have such adverse effects as sialadenitis, dental caries, epiphoria, gonadal dysfunction, marrow suppression, and to some, the potential for secondary malignancy. So to reduce adverse effects, obviously the strategy should either be don't use radioactive iodine, use recombinant human TSH or Thyrogen for preparation of administration of radioactive iodine, and finally, to use lower ablative doses of radioactive iodine on the order of 30 millicuries. Well, everyone also agrees that patients with high-risk tumors should undergo radioactive iodine, and these are the guidelines showing don't give it to low-risk tumors, give it to high-risk tumors, and I've highlighted intermediate-risk tumors where the guidelines have suggested consideration of radioactive iodine, but without a clear-cut recommendation. So our research group said, what a great question to ask. In the end, is there survival benefit from radioactive iodine for patients who have, say, cervical lymph node metastasis? Should they undergo radioactive iodine? So this is a study that was published in 2015 in the Journal of Clinical Endocrinology and Metabolism, and this is an unadjusted survival analysis where you see that there is a statistically significantly improved survival rate for intermediate risk PTC patients who receive radioactive iodine. We then redid this survival analysis using a multivariable adjustment model, and highlighted at the bottom, you will see that when radioactive iodine is administered to intermediate risk patients, there is a reduction in mortality of approximately 29%, and this was a highly statistically significant finding. So, in this case, less may not be more, and giving radioactive iodine may make sense. Well, how should we prepare patients for radioactive iodine? Well, I'm not sure there'll ever be consensus about that, but certainly guidelines are now suggesting that for low and intermediate risk tumors, recombinant human TSH stimulation is a reasonable alternative to withdrawal and certainly is associated with superior short-term quality of life. But for American Thyroid Association high-risk differentiated tumors, there's no recommendation, meaning either recombinant human TSH or withdrawal would be acceptable options. To finish up, what can we conclude? I think the only safe thing to say is that there has been an explosion in research and an explosion in the kinetic of science surrounding thyroidology and particularly differentiated thyroid cancer. And almost certainly, as new data are published, we should continue to reevaluate as providers what we're doing and to be open to change when there is evidence to support that practice change. I'd like to finish my presentation by acknowledging all of my colleagues in research in the Endocrine Neoplasia Diseases Group at the Duke Cancer Institute, the Duke Clinical Research Institute, and in the Department of Surgery at Duke. It would certainly be unable to do this kind of science without a transdisciplinary platform. Thank you so much for joining us today.